Hello, everyone, and welcome to our podcast today. This podcast, the second in our series, focuses on patient proning and best practice strategies to manage the risk of hospital-acquired pressure injury in patients with acute respiratory distress syndrome associated with coronavirus disease 2019 or COVID-19. COVID-19 became a global pandemic in a short time, and clinicians on the front lines of the pandemic collaborated to bring effective treatment modalities to the forefront. Prone positioning is one of those treatments and is recommended in hospitalized patients with COVID-19 to improve oxygenation and reduce respiratory effort. I'm Julia Rian, the Associate Director for Clinical Market Development, U.S. Advanced Wound Care at Convatec. During this podcast, we'll focus on prone positioning in COVID-19 patients and particularly strategies to manage the risk of pressure injury in these patients. Today, we have the privilege of talking with Tracy Thomas. Tracy is a clinical nurse specialist for the critical care areas at Dignity Health, St. Joseph's Hospital and Medical Center in Phoenix, Arizona. She has more than 15 years of experience in caring for critically ill adults, with a special focus in medical, surgical, trauma, and pulmonary arterial hypertension. And she is currently the president of the Greater Phoenix Area chapter of the American Association of Critical Care Nurses. Thanks for being with us today, Tracy.
Thank you for having me.
So you've been actively caring for COVID-19 patients with acute respiratory distress syndrome throughout the pandemic. Can you share some of your experiences with our audience?
Absolutely. So in Arizona, we have seen COVID-19 since approximately April 2020. During that time, my hospital system has cared for over 6,500 of those patients in the hospital setting. And we've seen anywhere from mild illness, which typically traditionally do not get hospitalized, to severe illness requiring things like prone ventilation, ECMO, some of the more complex treatments such as lung transplant after they survive their illness. And we have seen a little bit of a change in our culture with back to basics. For example, positioning our patients, making sure that we're looking at the prone position of our patients, that our patients have good pulmonary toilets so that they're coughing and that they're breathing, they're providing that deep breath. We've seen across the board various challenges with this disease, unfortunately.
So in patients with the ARDS associated with COVID-19, you talked about proning. Some of these patients can be prone for prolonged periods of time. I mean, sometimes up to 16 hours at a time, which inherently increases their risk to develop pressure injuries. What are the specific risks for the skin in these patients who are prone for these extended periods?
Well, I think when we're looking at these patients, they have some things going on with them that traditional patients may not necessarily have. And those that we look at they're diaphoretic. Oftentimes these patients are febrile. So the skin is constantly in that state of moisture. We know that oxygenation is a big problem. So if we're already having a problem oxygenating our vital organs, our brain, our heart, all of those structures, the skin, unfortunately, is not very high on the totem pole of oxygenation. So we know that that definitely also has an issue. We have shearing injuries with these patients because oftentimes they're sliding all over the bed. We might be repositioning them frequently to try and get better oxygenation. So we have a couple issues with them. We know that they also might have some altered nutritional status. That might be because of the condition that they have, if they have nausea, vomiting, diarrhea. So that's a problem with retaining those nutrients. We know that they also tend to be a little bit more dehydrated because of that diaphoresis. They may also be on the opposite scale and having renal failure and not excreting some of those waste products. So I think that definitely contributes to our pressure injuries. Looking at pressure injuries, when we look at some of the evidence that's really been studied, the face tends to be the number one site, especially if patients are facing head down and we're not giving a little bit of reprieve to that. Anything else that's really resting on those surfaces for that extended period of time, which can be anywhere from 8 to 24 hours, And that's if your patient is able to supine safely. They can even be prone for longer than that. I've had patients stay prone for days because they're just not stable enough to flip over. So then we would see things like breast tissue, right? Bilateral breasts, definitely the anterior thighs. If there's anything, any large abdominal cavity, that's also going to break down. Hips tend to break down as well. Lateral sides of arms, or, even just the dorsal sides of the arms, depending on how that arm is positioned on the bed. Anything that's really spent down in time. The number one that we actually see is probably going to be the face and or the mouth, just because of gravity taking effect, as well as they're typically on mechanical ventilation at that point. So that mouth tends to swell around that breathing tube.
And so the mucous membranes react in a different way too. I mean, with the mouth and the nose, not the skin we see on other surfaces of our body, right?
Right. Yes. And even looking at mucous membranes, you're looking at genitalia as well. So everything swells, right? And the body's going to take the path of least resistance. So wherever we have extra skin, it's going to swell. So if we have an indwelling catheter in, we have to make sure that we're padding around there so we don't have breakdown, we don't have deep tissue injuries from that. For the male gender, making sure that we have enough slack on those catheters so that it's not catching and causing ulcerations on surrounding tissues in that region. And same thing with indwelling rectal devices as well, fecal incontinence devices. Any of that really gentle mucous membrane tissue is prone to injury in this situation.
How should clinicians manage the main pressure points in these patients? Are there modalities like support surfaces or positioning devices that clinicians can use to manage this risk?
Absolutely. I think, when we started this pandemic, we saw so many opportunities for improvement. And over the past year, we've learned a few things. I think definitely looking at your support surface, if you're going to start from the ground up, support surface definitely. Looking to see if you have anything like microclimate management. That can be an overlay, that can be on your mattress. Alternating pressure therapies can work out great as well, especially for those patients that you can't perform micro shifts or turns because they're just too unstable. Anything that can allow that airflow would work well. Looking at support cushions, anything that can help redistribute or elevate certain extremities, for example, lifting abdominal contents between that pelvic bone, helping lift perhaps parts of the chest, especially with somebody that has large breast tissue. Pillows can work. Anything that, and even some of the most sophisticated things like some of the silicone beaded embedded pillows, or even some of the airflow pillows, or just standard pillows, any of those things you can utilize to your advantage. There's many things out on the market, including foam repositioners too, that can also help.
So how should uneven pressure redistribution in these patients be evaluated? How can the clinical staff know that they're effectively offloading these areas that are at risk?
I think when we're looking at the upper torso, really looking to see how your patient is matching the ventilator. Are you getting the outcomes that you would prefer? I think something else that we can look at is also performing microturns in these patients and checking underneath the skin if you can, looking under the skin to see, do I have any developing pressure areas? Do I have any deep tissue injury developing? Am I able to offload those and switch? For example, can I turn my patient side to side even while they're prone and just offload one side at a time? Even if it's something small and gentle and not a high amount of degrees, you're still providing that space for them. Extremity management, you can increase the arc perhaps of the legs one by one, and put more pillows on one side and then put pillows on the other side, for example.
So you referred to micro turns. So those are those really just slight movements. Can you explain that just a little bit better?
Absolutely. So we have a patient that's laying in the prone surface, and typically for our prone patients, we have them laying on a sheet or some sort of linen. What we would do is pick that patient up. We typically have about 2 to 3 people, including, and that does not include one that actually holds the head as well as the airway to keep that safety. And we'll pick up on one side and just lift that patient up on one side, gently place something under there. I've seen thin pillows. I've seen blankets. I've seen something to just gently offload that patient and provide a small amount of reprieve for that side. So typically turns, when you're turning somebody, you're looking at anywhere from at least, 20 to 30 degrees when you're actually putting them up, all the way up to 45 degrees. This is something very gentle, 10 to 15 degrees, something just to provide a little bit of air relief, as well as mobilize some of those lung contents as well.
So are there other clinical strategies that are effective in preventing the hospital-acquired pressure injury in these patients?
I think so. So something that we've done at the facilities that I have worked with is we will also go in about every 2 hours and we'll lift up the head, especially if the patient's head is facing in a downward fashion. We'll lift up the head, we'll clear the secretions, make sure we have a nice dry environment. The use of things like skin prep barriers, so important for your diaphoretic patients to try and reduce some of that pressure breakdown as well. Pick up the head, make sure that we have everything smooth, maybe change out the pad that's underneath if it's wet. And you can do that too, for example, if you have anything like drains, if you have leaking IVs, anything of that nature, if you can lift up that extremity, make sure we have no wrinkles in those sheets, dry the skin off, make sure that we don't have, if we're not in need of any additional barrier support, such as creams or sprays, and then reposition accordingly about every 2 to 4 hours if you can.
Okay, so can specific dressings play a role in treating hospital-acquired pressure injury in patients with COVID-19 ARDS? How would they be used?
So typically a dressing for that nature, you probably want something that is going to be a multi-layer dressing that can help withstand shearing. And we're going to get shear in these patients just from the act of proning them, from turning them side to side. We also get shear because we turn these beds in reverse Trendelenburg and gravity takes hold and those patients will slide down the bed. And that absolutely happens, especially with a lot of the mattresses that have microclimate, because that's a very, very slick surface. And our sheets are also very slick. So shear tends to be a big issue here, not just pressure injury breakdown if you're looking at that in that context. So a multi-layer foam dressing would be great. Definitely something that also wicks away any moisture. So when you get shear, unfortunately, and you also have a environment where you have swelling and fluid overload, you're going to get blister formation. So if those blisters rupture, you need something to wick away that moisture from the skin so we can prevent maceration and further destruction. So that's ideally what those dressings should look like. I would add another caveat to that is you need to have a dressing that is gentle enough on the skin so that you can lift it up to check underneath the dressing to see that skin environment underneath, but then be able to put it back down, smooth it back down. It doesn't rumple, it doesn't crumple, anything like that would be really important, I think, for a dressing.
So what are the benefits of hydrofiber dressings or perhaps a calcium alginate in managing some of this moisture and that risk of pressure injury in patients with COVID-19 ARDS?
Hydrofiber and calcium alginate do a wonderful job of wicking away that moisture from the skin. It really helps that wound bed from maintaining that over moist surface. It holds that and it holds it intact so that it's not really leaking all over the place. So from a blister formation standpoint, that is a great dressing to have to also prevent a bigger blister from happening. It's a nice methodology to utilize.
So do you recommend using these types of dressings in a protocol? How do we know where to apply these dressings?
Sure. So NPIAP has a great resource. It's an excellent resource for our prone patients. There's also several available. I know my facility also, we have one as well. And it depends on how you're proning these patients. If you're using manual prone, if you're using a prone positioner, or you're using a prone surface bed, anything like that, you want to put these dressings pretty much in a protocol fashion, just because the staff that are working with these patients may have never proned before. You also you may have one person, but ideally you have more than one person also working on these patients and helping you. So they need to know where these dressings go. Usually areas of bony prominence over any surfaces that have direct contact with that bed or positioner, whatever you're going to use. A protocol fashion really helps eliminate anything that you forget because you're busy. This is one of 50 things that you have to do with this patient that also, by the way, is really sick. So you want to make this as easy as possible for the staff. I would actually go one step further, have those dressings bundled together in a kit with some skin prep barrier cream so that they're able to just have kind of a one-stop shop, if you will, and just have everything that they need, where to put these dressings, and all the materials at hand.
So Tracy, thanks for your time today. Do you have any last thoughts that you want to share with us on patient proning and skin protection in these patients?
Proning works. Proning works. Skin protection works. Proning's been around since the 70s. We've used it, and I think with COVID, one of the great things that came about was you don't have to wait till your patient is super, super sick to prone. You start proning them earlier, and when your patient's awake, and I want to tell people that are also proning awake patients, consider using dressings on them because they're going to find that they are going to breathe better on their belly or on their side, and they can break down. They still have some of the same issues that our mechanical ventilated patients have. So consider using dressings, consider using great support surfaces or support products to help these patients so that they don't move down that path.
Well, Tracy, thanks so much for sharing your clinical expertise and your insights with our audience today. It's been a pleasure to talk with you on this podcast. On behalf of myself and Convatec, thank you. As clinicians, we've learned so much about the care needs of these complex patients during this pandemic. And for those of you who have listened to the podcast, we hope you've gained some insights that you can apply in your clinical practice. Thank you.